So at AACR, I'm presenting some of the biomarker analysis from the randomized multicenter phase 3 CRO study. In the study, Lorlatinib third generation ALK-TKI resulted in a statistically significant and clinically meaningful improvement in progression-free survival versus Crizotinib in patients with previously untreated ALK-positive advanced non-small cell lung cancer. And based on this data, Lorlatinib has recently been approved by the FDA as first-line treatment for patients with ALK-positive non-small cell lung cancer, advanced non-small cell lung cancer. And because data are conflicting regarding the influence of different EML4 ALK fusion variants or TP53 mutations on treatment outcomes in patients treated with ALK inhibitors, we look specifically at these molecular correlates of response to Lorlatinib, and we perform molecular profiling of circulating free DNA and tumor tissue at screening, and evaluated the efficacy of Lorlatinib in patients by ALK mutation, EML4 ALK fusion variant subtypes, and TP53 mutational status. We analyzed plasma DNA for ALK fusions and mutations by next-generation sequencing. Tumor tissue DNA was analyzed with an ALK mutation-focused next-generation sequencing panel. Objective response rate, duration of response, and progression-free survival were evaluated according to EML4 ALK variant type, ALK mutation, and TP53 mutation status. ALK fusions were detected in the plasma of roughly 50% of patients with plasma samples available. Of those with ALK fusions, EML4 ALK variant 1 and 3 were detected in more patients than variant 2 in both arms. Objective response rates were higher in the Lorlatinib arm than the Crizotinib arm for EML4 ALK variants 1 and 2, and similar in the two arms for variant 3. Lorlatinib achieved longer duration of response and improved progression-free survival versus Crizotinib in all fusion variant subgroups, and in particular for variants 1 and 3. Concerning ALK mutations, they were detected in the plasma of 12 patients at screening. Although there were few ALK mutations detected at screening, a higher objective response rate and a longer duration of response and improved progression-free survival were found in patients with Lorlatinib versus Crizotinib. Looking at the tumor tissue analysis, only one patient had a detectable ALK mutation in the Crizotinib arm, so we did not perform any further research. Shifting to the TP53 analysis, TP53 mutations were detected in slightly over 40% of patients, and while the presence of a detectable TP53 mutation did not seem to influence the objective response rate in either treatment arm, it seemed to influence duration of response and progression-free survival in the Crizotinib arm, with a shorter duration of observed when a TP53 mutation was detected. In conclusion, patients with untreated ALK-positive advanced non-small cell lung cancer benefited from Lorlatinib over Crizotinib regardless of the EML4 ALK fusion variant type or presence of ALK mutations at baseline. TP53 mutations did not seem to influence Lorlatinib activity, although they might have been associated with numerically shorter progression-free survival in the Crizotinib arm. Therefore, in the CRO study, Lorlatinib achieved a longer duration of response and improved progression-free survival over Crizotinib, regardless of the ALK variant type, the presence of an ALK mutation, or the presence of a co-mutation TP53.